Hello, everyone. And it's been a while since I had a guest on our life, and but when that happens, is always somebody very special who I think you guys are gonna really appreciate today. Dr. Felice Gersh is here with me, and we're gonna be talking about focusing on a topic that I don't often talk about, which is bioidentical hormones. Are they safe? Are they not? Are they the right thing for you? What kind of hormone? Should you DIY it or should you see a practitioner? I have a lot of questions for her about that. Welcome, Dr. Felice.
Well, I'm so pleased to have this chance to join you and your audience.
So you are a double certified OBGYN practicing out of Irvine, California. Is that correct?
That's right. I'm board certified in OBGYN and in integrative medicine. And I'm speaking to you live from my brick and mortar practice here in southern sunny California, Irvine.
Don't rub it in because we're just about to have a huge snow dump here in Colorado. So Dr. Gersh authored a book called Menopause 50 Things You Need to Know, which is a really interesting read. In fact, I heard you on a podcast and there was something you said that was really powerful. And that was you said, how women prepare themselves for pregnancy, but no one talks about preparing yourself for menopause. And I thought it was such a powerful thought. And I immediately got your book. So, hey, you guys, Menopause 50 Things You Need to Know. A really cool, short book, concise. I kind of like that because it's just an easy read to understand what's going on in your own body. You can get that on Amazon. So just look it up. I highly recommend it. One of the things that really stood out for me in this book is the different symptoms that we experience that are related to menopause. I think a lot of people know that it's like our cognitive functions are not the same. I walk into a room, it's like, where are the proverbial keys, right? My skin is beginning to thin, or I'm losing hair, and it's just, my sex drive is not the same. I think a lot of women connect that to perimenopause and menopause, but there's, I think, a lot of symptoms that you talk about here in your wonderful book, 50 of them, in fact, that are connected to menopause.
We don't think about overwhelming.
Could we talk a little bit about some of the most underestimated symptoms of perimenopause and menopause for women?
Well, I think that there are so many that are under recognized. For example, some of the GI symptoms like acid reflux. Now, a lot of women have GERD and acid reflux as they progress through menopause, but they don't even see the connection because estrogen, which of course is going to be produced in lower and lower amounts as time passes, as you enter into menopause, and ultimately not at all when you're fully, completely in ovarian senescence and your ovaries stop producing it. And estrogen modulates or regulates all of the neurological systems of the body, including the CNS, the central nervous system, and the ENS, the enteric or gut nervous system. So when you don't have adequate and balanced estrogen in the body, then you're not going to have proper peristalsis, or the movement of food down the line. And so you're not going to have proper stomach emptying, and the different sphincters in the body cannot close properly sometimes, and they open, and you can have, some of the stomach contents refluxing back into the esophagus, and that can cause the burning and discomfort and so on. The other thing I would say that's a very underestimated one is the alteration in the circadian rhythm that women go through. So because estrogen is also one of the regulators of the master clock that sits atop the optic nerve and senses light and dark, we have drifting of the master clock. So we often have problems with sleep that aren't really associated with menopause directly. Like, for example, early morning awakening, like when people wake up at 2-3 o'clock in the morning, they can't fall back to sleep. Their brain thinks it's like 6 or 7 in the morning, time to get up. But you look at the clock, it says 2 or 3 in the morning, because they have this phase defect that's due to alteration in the function of the master clock. So it's just like things that they're not put together, that, this is because I'm losing my estrogen. My hormones are different. So those are just 2 of many.
Yeah, and for those of you who are joining us now, we're talking about Dr. Felice Gersh's book, 50 Things You Need to Know About Menopause. And so the list is long, you guys. I mean, 50. She just talked about two. Let's do this. I'm going to read out a whole bunch of them that are covered in the book. And you tell us which ones would you want us to talk about before we dive into talking about hormones and how to use them. So we've got acne, appetite fluctuations, bladder and vaginal infections, blood work warning signs, brain fog, breast tenderness, facial hair, fatigue, fertility decrease, fibromyalgia, body pains, heartburn, hot flashes, insomnia. We talked about that. Lip thinning, menstrual irregularity, migraine headaches, and mood swings. PMS, sex drive decrease, early menopause. We've got arthritis and joint pain, body odor, bunions, constipation, diabetes, dry eyes, dry mouth, hair thinning, heart palpitations, hypertension, incontinence, urinary urgency, nail texture changes, shingles, wrinkles, sleep apnea, vaginal dryness, voice deepening, Alzheimer's disease, cancer, eye disease, falls, heart attacks. That's more for late menopause here. Muscle loss, osteoporosis, sleep irregularities, slow wound healing, stroke clotting disorders, tooth loss, vaginal prolapse, varicose veins.
Oh gosh.
Yeah, wow. This is like what's ahead of us, right? Yeah, so we've got requests for hot flashes, for joint pain. So why don't we talk about hot flashes and night sweats? Because we hear about this all the time.
That's the sort of, I would say, the calling card of going into menopause are the night sweats and hot flashes, which occur in about 80% of American women. So it's very, very prevalent. And let me just mention that they have many implications when they occur, because not only do they feel terrible, they can be embarrassing if you're just like sopping wet in your clothes. They are highly disruptive to sleep quality. I have patients that, when they come in, they tell me they're changing their sheets in the middle of the night. They're soaking wet in their clothing, and then they get chilled because they're lying in a pool of water from their sweat and so on. So they're disruptive in that regard, but they're actually now known to be associated with higher risks long-term for cardiovascular disease like heart attacks, strokes, and even dementia, because they're a sign of neuroinflammation. There's alteration in the sleep and thermal regulatory centers in the brain. So their temperature is a highly regulated function of the hypothalamus, that portion of the brain that regulates so many things like that we don't think about through the autonomic nervous system, like our pulse, our temperature, sweating. And these become quite dysregulated as women lose their regular hormone production and things are really changing. And the range that the body will accept for temperature sort of changes, and it ends up going into this sweating and hot mode, and especially at night, because everything in the body is on a timer. As people who have kids know, their temperature tends to go high at night and their fevers tend to worsen at night. That's why night sweats are so predominant in this group. So they're really due to this inflammatory process that's occurring in the brain. It's very disruptive. It's also a precursor or an omen of bad things to come with these organ systems like the cardiovascular and the brain. So we really don't want to just like put up the hold your chin up and just grin and bear it. No, that is not what we want to do. We definitely want to tackle it. In terms of who gets them the worst, well, that comes back to what we were talking about in the beginning about preparing for menopause, because we know that women who are overweight or obese tend to, in general, have worse hot flashes. Women who live like a more pro-inflammatory lifestyle, they're not eating all the anti-inflammatory foods and avoiding environmental pollution and toxins, endocrine disruptors. They live with chronic high levels of stress, which they don't manage. So basically, if they have a sort of inflammatory lifestyle, they're more prone to developing worse hot flashes. So, and diet and eating like phytoestrogen foods like soy and flax seeds, those actually can help. So if women, when you get them, that's actually a sign that, well, maybe you need to really take stock of your lifestyle, because the worst hot flashes do tend to occur in women who have these underlying sort of pro-inflammatory states. And in terms of, well, how are we going to address them? Well, I mentioned eating phytoestrogens. There was actually an article that came out not long ago that was a very interesting research study that showed that women who had significant hot flashes and night sweats, if they ate for 12 weeks, that was in the study, they ate a cup of soybeans, like organic edamame soybeans every day. By the end of 12 weeks, almost 100% of the women had dramatic reduction in hot flashes and night sweats.
Yeah.
So just changing the diet can help. As well, we do, sleep regimens where you make the room really cool, you make your bed really comfortable. You don't want to, pack on the blankets, of course. I love to sleep with a fan on me. It's just so soothing. So, you get a fan to help you to stay cool. So you want to help your body to keep those thermoregulatory centers working better. And then there are supplements that can be beneficial that also are based on phytoestrogens, like the different polyphenols, whether it's the isoflavones, which come from things like soy products, or the lignans, which come from things like flaxseed, or a newer one on the block is from Siberian rhubarb, the root of the Siberian rhubarb tree. So these are all supplements that are out there on the market that have, some of them have actually pretty good studies that show support, which is always hard to get when you're dealing with natural products, to get studies that show real improvement in these night sweats and hot flashes. And then there's definitely estrogen. So if you get really significant hot flashes, they're not improving with the lifestyle modalities, then definitely, unless you have a contraindication like something unfortunate like breast cancer, uterine cancer, most women are excellent candidates. And sometimes it doesn't take much, even a very small amount of added estrogen, like a little tiny dose of an estrogen patch, can really change the dynamics of this problem. And women can, by the way, have night sweats and hot flashes while still having cycles. Because if you do like menstrual mapping, which I order very often, so it's urine testing throughout a menstrual cycle, and you can actually map it, they map it out, and you actually see the rhythm of estrogen, progesterone, and the pituitary hormone LH through a cycle. And many of the women who have night sweats and hot flashes but are still cycling, when you look at their hormone levels, they are not normal. They're really all over the place. Their LH is really high, their estrogen levels are low, but they're still having cycles. But of course, their fertility is very low because their egg quality is very low, but they're still cycling. So don't be surprised if you get these symptoms and you're still cycling, because it doesn't mean you're not going through that transition, because it's different for every woman. We're all like little snowflakes, and some women, their periods abruptly stop. Some they phase out, some they get worse and more frequent because of ovulatory dysfunction, and some they keep cycling, but they have a lot of the symptoms. So you got to be prepared for any and all of the above.
Yeah, I'm glad you're talking about that. I notice it with myself as I'm still cycling, although I'm definitely going into perimenopause. My luteal phase significantly shorter, but I got hot flashes just a few months ago, and it was all due to two things: alcohol and I started drinking coffee for a while, and then I realized that is just bad. Is the inflammatory response, and even without adding any estrogens. In whether a natural form or whether it's a patch, and they went away the minute I stopped the inflammation. So
absolutely. I mean, it's amazing what you can do with, especially in the early stages of menopause, with lifestyle. And of course, I'm glad you mentioned, like, the last thing you want to do if you're prone to hot flashes is drink a lot of hot drinks. So don't do that.
Right. So let's switch gear a little bit. I would like to talk to you about something that I don't talk often about, and that's bioidentical hormones. Let's just maybe start off from a high level of the whole fear of bioidentical hormones. Are they safe? And are we talking about estrogen here, DHEA, testosterone, progesterone? Why don't you just walk us through on a fairly high level?
Sure. So sad to say, 20 years ago, there was this very large, well-intentioned, but didn't turn out too well, study called the Women's Health Initiative, often talked about as the WHI. And in that study, they used what was common in the day when they actually started preparing for that study, which was many years before the study actually was initiated, because it took a lot of pre-planning. And what that was, they used as their hormone therapy a conjugated equine estrogen, the brand name being Premarin. And what that was, it was the horse didn't even want it. It came from a pregnant mare, and it had already gone through the liver, and it was horse estrogens, and the estrogens were conjugated. That's why they call it equine conjugated estrogens. So conjugation occurs in the liver to transform, that's why they call it biotransformation, transform the estrogens, which were fat soluble, into water soluble, so they could go out with the urine, which is like water. So that's how it would be eliminated from the body. So the horse was trying to get rid of it. And what they did was they took this urine and then they dried it, made it like into a powder, and then they compressed it into a tablet. And it had a whole array of these horse urine byproducts, including some androgens, like male type hormones, like testosterone related products. They're also the horse was trying to get out. And included in that package of different hormones were types of estrogens that would never occur in a human female. They're really specific to a horse. And then they combined it with a pretend progesterone. They call it a progestin. Progestin is a man-made up word for a pretend progesterone. So technically, it's an endocrine disruptor for progesterone. That means it binds to progesterone, which is the human-produced product that we call progesterone. It binds to those receptors, but it can have varying effects, like it can turn them on, turn them off, turn them halfway on. So it can have a whole wide array of different effects in the body than the real human progesterone would have. And similarly, when the estrogens that were in the conjugated estrogen product, the Premarin that went into the body orally, they got altered by the human digestive tract and went into the bloodstream as this wide array of these horse type estrogens. And the human type that it would go into the bloodstream would be called estrone. So first, to know that estrogens are a family of hormones. And there are different types of estrogens. The estrogen made by the female ovary during the reproductive years is called 17-beta estradiol. We usually just call it estradiol. And it can be converted in the body into estriol and estrone in smaller quantities. And the body decides when and if it should make those conversions. But estrone only works predominantly on one type of receptor, because there are different types of receptors for estrogens, and it's called alpha. Estradiol, the estrogen from the ovary, has a balanced effect on all the different estrogen receptors in the body. And different organ systems of the body will have a predominance of one type of receptor or another. Like the gut tends to be more beta, and the hypothalamus in the brain tends to be more alpha. The innate immune cells of the body, like the neutrophils and the macrophages and the monocytes and the mast cells, they tend to be alpha. So there's every different organ system will have a different prevalence, and arteries tend to be more alpha, but there's often a blend. So it's very complex, and the receptors interact with one another, so they up and down regulate each other. This is like a dynamic situation, and it's totally different when you only have estrone coming in. So what we used in that Women's Health Initiative study was essentially horse estrogens with estrone, and then this mimic for progesterone that had very different effects. So the ultimate outcome was that there was a small increase of strokes. There was a small increase in the incidence of breast cancer in this study. Actually, both of them were quite small. There was a significant 4-fold increase in blood clotting because of this. And the conclusion was don't use that product. Sad to say, the ultimate, although that wasn't what was written in the study, that is what was practiced in the world of medical care. and that was sort of the message that ended up getting delivered, was don't use any hormones. So it would be like you did a study with strawberry flavored jelly beans, didn't find that it did a lot of good for the body, but the conclusion was never eat organic strawberries.
Right.
It's as crazy as that. So when we use human bioidentical hormones, hormones that are identical to what the ovary actually produces during the reproductive years, the effects are so different. So we need to like change our mindset and all the thinking that you had. So think of it as you don't want to use what they studied in that study, but that is not what real human hormones do in the body. We have so much data on what happens when you have human hormones in the female body and what happens when you don't have them. Now, what we don't have is tons and tons of studies on what happens when you properly replace the hormones with human bioidentical hormones at physiologic doses. In other words, trying to get the levels in the body to similar levels that you would have when you're at your healthiest, like say 21, 22, and so on. We unfortunately don't have a ton of those studies, or even a little bit of those studies, because after the Women's Health Initiative was shut down after very few years, everything came to a halt. Estrogen was vilified. Everyone started saying, don't use it, or if you have to, just use the tiniest amount for the shortest period of time. And it's really hard to undo that, like really brainwashing effect. But we know from at least some of the studies that came out subsequently, for example, one study called the ELITE study, which actually did not use the right hormones. Once again, because the people who formulated the studies still didn't understand the difference between oral estrogen and transdermal estrogen. When you give estrogen to menopausal women or transitioning, it has to go through the skin, because otherwise it gets altered by the digestive tract back into estrone, and we want estradiol to get in the body. But unfortunately, they gave the wrong estrogen. But even with that, what they showed was benefit to the arteries in younger women, like just a very few years out in menopause, and no harm at all to women who were out more than 10 years. So that was at least a really good thing. As well, back in 2017, the North American Menopause Society came out with their revised position paper on hormones. And in it, they actually gave permission, not that you need their permission, but it's nice to be validated and to have a big, very respected, very conservative organization for menopause, research and so on, for clinicians, that they came out in their new position paper back then and said that you can use human bioidentical hormones and you can use them for the life of the woman, that there was no end date. And what they said was you can use it for the following 3 reasons. The 2 FDA approved reasons, which are to suppress and control menopausal symptoms like night sweats and hot flashes, and for bone health. Those are the only 2 systemically, like when you take it through your whole body, approved FDA reasons for using hormones. But then they added the 3rd one, which was brilliant. I give them all the credit in the world, for quality of life. So that really opens the door to everything. Everything. So now women can stay on hormones and embrace them, love them, recognize that all you're doing is replacing what nature took away, and that these hormones are about maintaining. They're not, in obviously a menopausal woman, about maintaining fertility. That's gone. So it's not like it's going to make you fertile again. That's not going to do that. But hormones, these hormones are not just sex hormones. They're body-wide hormones, because nature put those hormones in the body for the purpose of reproductive success, which means you have to have a healthy body, because an unhealthy woman has all kinds of complications when she's pregnant. So they maintain the whole body in a beautiful synchrony, organization, and function that makes optimal health possible. So we need to recognize these hormones are for every organ system of the body. That's why when we lose them, we have that wide array of problems that you read off from the book, because every organ system takes a hit. and we can replace these hormones now. It's totally appropriate. It's very safe when done properly. We want to not give the smallest dose. We want to give the most efficacious dose, just like with vegetables. You'd never say, well, I want you to eat the smallest amount of green leafy vegetables possible. No, you'd say, I want you to eat the most that's going to give you the most benefit, right? You want everything should be the right amount, not the least amount, because that gives the idea that you want to give the least dose, possible, because you're trying to avoid something that's bad for you. But these are good for you. Yeah. And remember, different women go through menopause at different times in life. Like unfortunately, I think because I was up all those nights delivering babies, that I went through a very early menopause in my early 40s, which is really bad for women. Under the age of 45 is called early onset of menopause, and it's not good for you to lose your hormones that early. That's the other thing that we know. We know what happens that when women lose their hormones and go through early menopause, they have a greater array and an earlier onset of all of these so-called diseases of aging, which are really diseases of hormone deficiency. And but so women sometimes, like me, will go through menopause in their early 40s and others in their late 50s. That's a big range there. So It's not like hormones go from being good to evil at different times in different women's lives. They're always good. It's just that nature only gives us just so much, and then we run out. But we don't want our life to run out or to get any of those things. So we add lifestyle plus hormones, and we have optimized health at every stage.
I want to, for those of you who are joining us a little bit later, I'm talking to Dr. Felice Gersh. Her book, Menopause, 50 Things You Need to Know, is available on Amazon. Wonderful, short, concise, easy to read book. But you also have a private practice. You practice out of California, Irving. Do you also do remote consultations?
I do. So depending on the state that someone lives in, right. I sometimes have to have them come and see me once or twice a year in person. It depends because of the way that medical doctors like me are licensed.
Yeah.
We can always start off with a virtual visit. We have a wonderful telemedicine portion of my electronic medical record system. And then you can see if it's right for you, before you start buying plane tickets, and then see if it's right, and then decide. There are a couple of states that you don't have to actually come to see me, but of course I'd love to have people come and see me. But fortunately, everyone wants to come to Southern California for a little vacation anyway. But I have to go by the rules. The rules are, medical licensed professionals, depending on the state you live in, they do have to come in person sometimes, but not too often usually.
Your website is Integrative MGI, so Integrative Medical Group. Integrative, is it?
Well, it stands for Integrative Medical Group of Irvine. There's no O there for of.
Okay.
So it's just integrative, right, MGI.com.
So I know there's a lot of you posting questions, so we're gonna get to your questions in just a second. I'm gonna ask you a couple of things first before we open it up. So my first question is, you see a lot of people follow us because I advocate the most natural way of rebalancing your hormones, starting off with a diet, doing a lot of things for your sleep. We talk a lot about constipation, liver support, blood sugar balance, and controlling all of that through diet, supplements. But I feel like there is a fork in the road at some point where you can do a lot of things through nutrition and mitigate a lot of the different symptoms. However, it might come to a point where that just isn't enough. And I recognize that. And I'm not going to be one of those who's like, there's either food and supplements or nothing else, and forget the hormones, right? At which point would you say it's like that pivotal, is that fork in the road where you know that maybe that nutrition and lifestyle isn't enough, and seriously considering doing hormones, whether it's estrogen, progesterone, being guided by somebody like yourself, is time to do that? How do we know what is that point?
Well, I love to monitor. So always start, by the way, no matter what stage you are in life, lifestyle is always like the hugest component.
Foundational.
Always foundational, right? If the periods are very spaced apart or they're gone completely, and the official definition of menopause, which is arbitrary, is 12 consecutive months without a spontaneous period. So that's the diagnosis officially of menopause. But of course, it's a process. It's not like you cross a finish line. It's really declining ovarian function. And that speed of decline will vary from woman to woman. Some kind of go down a slow slope and some go like right off a cliff. So, everything has to be individualized. Certainly, if the symptoms of menopause are not being remediated by lifestyle, then you need to go think seriously about adding hormones. Once the periods are very spaced apart or they stop altogether, that means, your estrogen levels are so low at that point that you no matter how much you do good lifestyle, you're not going to you're going to do better, but you will do better yet if you add in the hormones. And that's why I talk about like your health savings account. So that's part of the thing. If you enter into this transition into menopause and you're already at an optimally healthy state with great muscles and bones and your brain is working well and you've got, great blood pressure and your cholesterol is right and you don't have inflammation markers that are elevated. So you're really healthy when you hit this onset of menopausal transition, what I call the first phase of menopause. If that is where you are, like you're in great shape, honestly, you'll be able to go much longer without the hormones. I call it the halo effect. You have such good health, it will carry you kind of like on the breeze, like if you're an airplane and the motor, all the engines go out, you'll turn into a glider if you have that good health. If you don't have it, you're going to turn into a dead weight. Exactly. You're going to crash and burn. So you have to really individualize. But certainly if the symptoms are out of control and lifestyle is just not doing it, you have too much inflammation, you have too much baggage, like a bad health, we need to think about hormones. I love to get lab tests because you can't, for me, I want to monitor. And if I never measure, I can't really monitor how things are going. So for someone who has already like maybe really abnormal lab work in terms of like their lipids are really terrible, adding some estrogen has been shown to improve like liver ability to pull cholesterol out, what we call LDL receptors on the liver. So then, it's kind of an adjunct that will help you as you're transitioning if you have that estrogen along with the lifestyle. So certainly the symptoms don't abate with the lifestyle treatments. Your hormones are really gone, like you're not having any more cycles, or you really have a lot of metabolic dysfunction, that having loss of estrogen. So estrogen regulates the immune system and also directs where fat is deposited. So that's how a girl goes through puberty, and she has a twin brother who goes through puberty. And then fast forward, from age 7 to age 17, they're not going to look the same, even if they eat the same diet, do the same activities, live in the same house, because the hormones are destiny for how like fat is deposited. Girls are going to get.
What do you see like with women, women's estrogen dropping? Where do you see the fat being deposited the most?
Oh,
that
belly fat. That's the thing. Without estrogen, you go into this default state, and women. I mean, I never saw a single woman who actually likes to see this body transformation where she will say to me, I'm eating less, which is not necessarily not a good thing because she's not getting her nutrients. So she's sometimes even starving herself, and she still sees like her arms and legs getting less muscular, and she's getting all this belly fat, and she just feels so bad. And that's a clear sign of systemic inflammation and lack of adequate estrogen. And so, we definitely can help women with that, with a combination of lifestyle and adding back. And it's really good when you start seeing that kind of body transformation and the belly fat and loss of muscle mass, which we call
it's a signal.
It's then we definitely want to think about getting those hormones going, because estrogen really controls fat tissue. People don't think about it. And the hormones that come out of fat is a very active metabolic tissue, and it makes hormones that like leptin and adiponectin that actually control appetite and fat burning. So those actually become dysfunctional when you don't have enough estrogen. So you get appetite that's completely dysregulated, and you don't know when you're hungry, when you're not, but you always eat anyway, and you can't control it. And you get the night binging cravings, and you also can't burn fat well. So estrogen helps all of that. So think of it as your best friend, and you have to work with your healthcare professional to decide, because there's no absolute, like pathway that everyone has to follow for when is it the right time to start on the hormones.
So I know you talk a lot about estrogen. We have a question that came in, which I think is a really good one from Delisa Ann. She says, so we can take estrogen only or progesterone too with Kaiser prescribed. So let's take the Kaiser thing out for now. Let's talk about progesterone here. So you talked a lot about estrogen. What about the progesterone in the mix?
So the way I look at it, like estrogen is like Batman, progesterone is Robin. They really go together. They're a team. The dominant player is estrogen, but progesterone, I never want to belittle progesterone. Progesterone is neuroprotective. There are receptors throughout the body for progesterone. And in terms of the uterine lining, that's where it actually had a lot of focus. It actually acts as sort of the contrary to estrogen. So when you have a normal menstrual cycle and you have the high progesterone in the second half of the luteal phase, that actually downregulates the estrogen receptors. So it sort of dampens down the growth effect or proliferative effect of the estrogen. So they work together. They kind of like, it's a real team effect. And estrogen upregulates the progesterone receptor. So you do need them both. And I always give progesterone to a woman, whether she has a uterus or not. That's so important because progesterone isn't just about the uterus. Progesterone, like I said, it's about skin health. It's about brain health. It's about bone health. It's all over the body doing important things. But progesterone in the body in a woman at reproductive age never is produced by the ovaries the same amount every day. So if we're going to go against nature, which we are when we give hormones after menopause, because nature took it away, but we don't like that. You know what? I would rather give back hormones than give joint replacements and lens replacements. I mean, we put phony baloney replacement things in the body all the time. I'd rather give back human biologically identical hormones so that you don't need to have cataract surgery and joint replacements and stents in your arteries and all those things. This is being proactive. So we definitely want to look at giving progesterone and estrogen to somewhat, not identical. We can't replace the ovaries in the way they make hormones, but to at least somewhat mimic what the ovaries did when you were reproductive. So that means giving progesterone only 2 weeks out of every month, not every day the same time. The reason that regimen developed, where you give progesterone and estrogen together every day, the same amount, was sort of based on the idea of birth control pills, which is about as unnatural as you can get, right? We're not trying to mimic birth control pills here. We're trying to mimic a human, healthy, reproductive woman's hormones, not birth control pills. So the idea behind that is that women after menopause will not accept having bleeding, like a fake period, bleeding from the uterus coming, like a period. They won't do that. They won't accept it. So we want to give progesterone and estrogen together to try to prevent that. That's like putting the gas and the brakes on in your car at the same time and expecting to get where you want to go. That's what's happening.
It's such a disservice to women. I mean, especially women after hysterectomy are put on an estrogen protocol, and most of them are synthetic ones, and never added progesterone because they go, you don't need progesterone anymore. I never understood that. We have a good question about blood clots. Do you worry about blood clots I'm assuming, when you prescribe hormones?
Actually, the only risk for blood clots comes from oral estrogens.
Right.
So because they convert into estrone, and estrone is sort of the pro-inflammatory. So estrogen regulates the inflammatory response. So we need inflammation if you get infections, if you get like a pathogen coming in your body, or you have trauma. You need to initiate inflammation. So estrogen actually works with the immune system to initiate inflammation, but it also works with the whole process of quelling inflammation and then having resolution and healing. So if you only have one type of estrogen, like estrone, you get stuck in the pro-inflammation thing. And part of inflammation is activating platelets into creating blood clots so that you don't bleed to death, for example, So that's why you need to have blood clots, but no, you're supposed to have blood clots when you're bleeding to prevent the blood from keep flowing out of you. You don't want random blood clots in your veins throughout your body or in your legs or in your lungs. But estrogen regulates that as long as it's not oral estrogen. So there was a French study that showed that when you give transdermal or through the skin estrogen, it has no negative effects on blood clotting. It does not promote blood clotting. And in fact, in a normal, healthy, reproductive age woman who has estradiol keeps platelets from what we call aggregating and creating blood clots. Estrogen regulates a whole enzyme system called the prostacyclines that actually prevent random blood clotting of with platelets activation. So estrogen keeps that from happening when you have the right estrogen in the body. So that's important.
A question we often get, and I'm sure people are wondering about that too here, is what about women who have a history of estrogen receptor positive or progesterone receptor positive breast cancer? Then what? And they're clearly showing symptoms of they're in full swing menopause with all the symptoms that you described. Would you prescribe it or not? And if yes, then what are the precautions?
Well, just as a quick preface to that, estrogen doesn't cause breast cancer. But if someone has a lot of inflammation, that causes DNA instability, and then they can have cancer occur. So it's underlying inflammatory status that actually promotes the DNA breakage, the instability, and not having enough estrogen doesn't allow cells to properly recycle and have the immune cells gobble up bad cells. So lack of adequate estrogen in the form of estradiol actually is more pro-cancer, lack of estrogen. But if you have inflammation, you can get cancer. But if it's in an organ that has estrogen normally, like the breast, so that those cancers that form in the breast will often have estrogen or progesterone receptor positivity. Then all the genes are expressing themselves differently. It's like a different creature. And if you add in those hormones at that point, they can be like an accelerant. They can actually, because like estrogen is about healing and growth and nurturing. And we didn't get programmed genetically to recognize things like breast cancer at that stage. So sort of it's like estrogen is hijacked. Instead of creating healing and nurturing, it's actually healing and nurturing the breast cancer. So it can promote its growth. So we really do have to think of it totally differently in a situation where someone has a hormone positive receptor cancer, like breast cancer or uterine cancer. And then we can't give those hormones. We just can't. Now, if someone is cured, okay, essentially in every sense of the word, like they had ductal carcinoma in situ, which some don't even want to call cancer anymore, and they have a lumpectomy, they don't have any problem with lymph nodes, there's no sign of any cancer, then it's still not officially recommended. You have to get informed consent. But in women who, as by every way that we can judge, there's no way to 100% judge anything, but there's no reason to think they have residual breast cancer in their body. Okay, then you can do it. You have to sign releases and waivers and all that kind of thing. But then it's possible. But the problem is also that a lot of women, even with very minor in terms of quantity or type, like ductal carcinoma in situ, they still want to put women on anti-hormonal treatments. Treatments that block the production of hormones or the receptors of hormones and such things. And I'm not going to go against the oncologist. I'm not going to tell women, but if they've been out from it, they're not on those things, and they really feel quality of life and other issues, related to estrogen deficiency really dictate that they want to go on hormones, and they fully are informed and they have no obvious residual cancer and all of those things, then, you can do it. It's legal. It's not illegal. But it's not the general standard of care, and that needs to be understood. So that's always a difficult group. But there are things that we can do where all the lifestyle things come in, like eating all those phytoestrogen foods and taking certain types of supplements that have been shown that they stimulate as phytoestrogens the beta receptor. And the beta receptor does actually downregulate the alpha, and breast cancer is always alpha receptor.
Yeah.
So if you give the foods that stimulate the beta receptor, it's actually anti-breast cancer.
Yeah.
And so those would be okay, and there's some like the one from the rhubarb plant that actually has published data to show that it probably is anti-breast cancer, not pro-breast cancer.
Yeah.
So there are things we can do when we can't use estrogen. And of course, those are the things that we do for women who just don't want to go on estrogen. So we go back to those, and then never underestimate the power of the mind. So mind-body practices can alter the way the autonomic nervous system reacts. And that's the part of the neurological system that controls things that we never think about, like peristalsis, our temperature and sweating and our pulse. And they can actually modulate through meditation, guided imagery, essential oils, and progressive relaxation, tapping. All these different modalities that are mind-body medicine can actually have a major benefit on controlling blood pressure and sweating and night sweats and all those things. So we do have many tools that we can apply effectively for women who just can't do hormones.
Let's dive into some of the questions, Kamalani, if you want to pop a few. And so we have a question about the nervous system. Can you speak about the nervous system? She had a complete hysterectomy 12 years ago. My nervous system is being affected and no answer from doctors.
Oh, that is painful to hear. So there are receptors all over the brain for estrogen and progesterone. And in the brain, the hypothalamus portion that controls memory and all the autonomic functions and basic metabolic functions, that's predominantly alpha. And the cortex, which is a lot about thinking, like our cognitive functions, that is beta receptor. So we have tremendous effects on the brain when you don't have estrogen. And we know that there's an immune system of the brain that is called the microglia, and they are regulated by estrogen. So without estrogen in the brain, you are more inflammatory, you don't make enough serotonin. These are neurotransmitters, acetylcholine. So and by the way, Dale Bredesen, who wrote the book Reversing Alzheimer's, believes that women for brain health should start hormones unless there's some major contraindication. They should start on hormones no matter how far out they are, because it will help to get the brain healthier and better. So we know that women compared to men will have 2 to 3 times the incidence of Alzheimer's disease. Mm-hmm. Women, because the blood vessels rely on estrogen to be healthy. After age 65, women have more hypertension, and vascular dementia, where you don't have proper blood flow into the brain, is also affected by estrogen deficiency states. Yeah. And all of these are interlinked with mood and sleep, because there are specific neurons in the brain called serotonin neurons that make the neurotransmitter serotonin, which makes you feel happy and peaceful. And serotonin turns into melatonin, which allows proper sleep when you have a massive blood flow to the brain at 2 o'clock in the morning when you're sleeping properly. That helps rejuvenate the brain. And it's not going to happen properly if you don't have adequate melatonin and quality sleep. Yeah. So really think about going on the phytoestrogens, because they're beta. That's the cortex of the brain, the cerebral cortex. And also talk to your doctor or look for someone who practices, cognitive repair, like the Bredesen protocol, to get someone who will prescribe hormones, even though you're more than 10 years out, unless you have like a contraindication, because there is hope that you can still get some significant regeneration and have better brain health, which includes cognitive and mood. Yeah, at this stage and never underestimate, once again, lifestyle, because they've shown that, for example, exercise can have a tremendous improvement on brain function. Totally. So, it's the spark of life when you exercise. And there are foods that are like fasting and exercise mimetics, that they mimic the benefits of doing these things that you can also add into your toolbox to help you. So never underestimate lifestyle. to help, just exercise and doing sleep hygiene, and perhaps taking some melatonin, and also, eating all these anti-inflammatory foods with, that contain natural phytoestrogens and polyphenols and antioxidants to reduce neuroinflammation in your brain.
Let's dive into the next question from Lori. She says, I still can't sleep. I'm on an estrogen lotion, almost no more hot flashes, but still can't sleep.
Well, I have no idea what estrogen dose you're on, and even knowing the dose doesn't tell me what's actually getting into you. So we need to accept the fact that skin really didn't evolve as a hormone delivery system, and everyone's skin is different, and we're just really we're just so clever to think of putting stuff on our skin and getting it into our bloodstream. That wasn't what skin was put on us for. It's actually a barrier, So, you may not be getting enough absorbed. And, I don't know if you're taking progesterone. So I would get some blood levels and just see. So when you're looking for blood levels of estrogen, it's estradiol that you want to measure. And you want a level at least of a 50 and somewhere between 50 and 150. So, there's a range, and it will vary during the day as well, because nothing is time released perfectly. So, see where the level is. Now, that said, no matter what and make sure you get progesterone. By the way, progesterone helps to produce the neurotransmitter GABA. I mentioned estrogen makes serotonin possible, and also acetylcholine, which is memory, and serotonin, the feel good, and then the melatonin, sleep. But don't underestimate progesterone. Sometimes adding a little progesterone is unbelievable for sleep, because progesterone promotes GABA, the sleep neurotransmitter. So make sure that you're getting adequate levels of all of those hormones. And then once again, add in sleep hygiene. Many people watch a lot of screens, and they suppress their melatonin production with all that blue light. So make sure that you turn off all computer screens, television screens for at least 2 hours before you go to bed. Don't eat for at least 3 hours before you go to bed, because you're not supposed to be digesting at that time of night. And that will disrupt a lot of things going on in your gut, where, remember, you have all those microbes, trillions, and they're actually producing all kinds of interesting things, including neurotransmitters like melatonin. So you really want to make sure that you nurture your gut and feed your body and them at the right time. So have an early dinner. Don't eat late at night. Make sure you go to bed no later than 11. The room really dark. Turn off screens for 2 hours and see the sunset. I know that sounds like so romantic, because it kind of is, but the colors of the sunset will actually help you to dampen down your cortisol levels and help you to bring up your melatonin levels. And then there are some herbals like L-theanine, ashwagandha. There's so many, there's hops, and there's lemon balm and passion flower, many herbs that are sort of calmatives and sort of gentle sedatives that will help you to sleep as well.
Lori, it's everything that Dr. Gersh said. And we have also, I've actually written an article after 8 months of researching on myself using my Aura ring, just to determine what impacts my sleep. And that ended up writing an article over a course of 8 months of observations and studies. And so, Lori, if you go to hormonesbalance.com, there is an article that's called How to Fix Your Sleep After 45. So everything that Dr. Gersh is talking about, and there's a few other things in there like magnesium, alcohol. I can tell you the thing that kills my sleep is if I stare at a computer, or if I'm on my phone before bed. So the blue light completely killing melatonin production. I do use, because sometimes you just have no choice. And a lot of people go like, then what do I do for this 2 hours before going to bed, right? We are so screen addicted. There's some really good blue light blocking glasses, but you've got to get those ones that are like really dark orange. They do change the colors, but I find that helps. And for me, the other thing is alcohol. I mean, and I'll fall asleep, but I'll wake up at 1, 2 o'clock in the morning, and I have a real problem going back to sleep. And so, and there's a few other ones as well. So something to consider.
Oh, I want to just jump in those are just making me think of a couple of things. One is to get a light box. And if you wake up at like 2, 3 in the morning, that's a sign of a phase alteration. And if you put like 10,000 lux with this light box and you put it on for just 15 minutes around 8 p.m., that will help to push your phase to the point where you won't hopefully wake up at 2 or 3 because your body thinks it's 7 or in the morning. So just that light box, for 15 minutes, 10,000 lux. And also if you urinate a lot during the night, like we call that nocturia, and you also wake up during the night, even if it's like briefly, and then sometimes you can't fall back to sleep, that is a high suspicion sign for sleep apnea. And that you need to get a testing for, and they have home studies now. You can also see some of that with an Oura ring, right? You can see what's going on. So we have so many do-it-yourself biohacking devices, but you can get your doctor to order an official, home sleep study and see if you actually have sleep apnea. And then, you have to address that as a separate issue. But women after menopause double their risk of developing sleep apnea because of alterations in how the brain is working.
Hey, you guys. So Sue, let's get over Sue's question. So what about hair loss is driving me crazy?
Well, hair loss is, we call it androgenic alopecia, or an aging-related hair loss, and it occurs in at least 50% of women. And I'm sure you've all seen women who are elderly or in nursing homes, and they all have wispy little hairs every which way. So a lot of people think it's all about testosterone. And it does relate to testosterone. And what happens is, as women transition into menopause, their ovaries cease to produce estrogen, but they still make testosterone. Women make testosterone their whole life. It does decline in how much, but they still make it. And there are receptors on the skin and in the scalp for both estrogen and testosterone. And testosterone can get turned through the enzyme into dihydrotestosterone, which is the more powerful one. And estrogen and inflammation actually controls a lot of the function of that enzyme. So if you don't have enough estrogen, you get more activity and more inflammation that also drives inflammation in the body, drives that enzyme to produce more of the dihydrotestosterone. And so then that creates, in people who are genetically programmed, the female version of male pattern hair loss, but it's the female version. So what can you do about it? Well, there's PRP, which I do in my office. It's called Platelet-Rich Plasma, where you concentrate through blood draw of your own blood, and it goes in a special centrifuge, and you get this portion of the blood that concentrates the platelets. They're injected into the scalp in the areas that are thinning with the hair, and it takes hair that's still there. It doesn't bring hairs that are dead back to life, but as long as there's a little wispy hair, it helps to create. Remember, platelets are about healing, and they're part of the resolution phase and the active phase of inflammation, and it's about healing. So we harness these amazing abilities of our own platelets to help rejuvenate the hair follicles and bring them back to life and grow better hair. And there's studies that show that if you combine that with minoxidil, the brand name was Rogaine when it first came out on the market, minoxidil, and published articles in the derm literature, if you use the minoxidil, which is like drops that you put on your scalp, and then you do the PRP together, you'll have in general, a significant improvement in the regrowth of hair. But you need to get on this early, because once the hair, what happens is the hair follicles, they call it miniaturized. Every time the hair falls out, the follicles get thinner, smaller and smaller. The hair coming out of it gets finer and finer. And eventually the last hair falls out, because hair always goes through cycles of growing, resting, falling out, growing, resting, falling out. And once the hair follicle, it will close over at some point. And then we have no way of bringing that back to life. And that's too late. We have nothing that we can do other than, transplanting hairs and wigs. So basically, you got to get on that early. So if you see that's happening, and then you can do the minoxidil and the Rogaine, and also hormone therapy. Because if you have reduced inflammation in the body through lifestyle, remember, inflammation drives the conversion of testosterone to dihydrotestosterone. And after menopause, you have this imbalance with actually, they always talk about estrogen dominance. They should talk about testosterone dominance, because you have enough, and then you end up with this sort of, even though your levels are actually low, you have not enough estrogen to balance it. And estrogen increases the production of something that's called sex hormone binding globulin, which actually holds the testosterone hostage. So it can't actually work on things like the scalp. So, and that's why a lot of women, as they transition into menopause, they feel like they're going through their teen years again. They're getting breakouts. So like, what's with this acne? It's because they have this imbalance of testosterone and estrogen. And some women develop extreme acne as they go into menopause with extreme hair loss. So that's a really horrible state.
And let me just build on that, because that's one of the things you talk about in your book, is that excess testosterone also being a cause for facial hair in women, right?
Right. And then you see all the old women with all these little beards, right?
Right.
That's like what we should do, like write a new book, called Testosterone Excess of Menopause, right? Because people are never thinking that way. And it's really, but it happens because you don't have enough estrogen. It's not because you have so much testosterone. The levels are not high at all. It's just you don't have enough estrogen, and like everything in life, it's all about balance, right?
Balance, yeah.
And we don't have that balance. And women who are genetically, just like men, the same kind of genes that make men more prone to getting male balding, right? That's the same thing that happens to women. And it's a very high incidence, and no woman likes to have thin hair. Let's be real about that. And then there are also these other things. I actually don't use them, but there's a little data for it, like laser caps, things like that for hair. But you got to get on it early, girls, because I'm telling you, once the hair follicle is closed over, we can't bring that back to life. No way, no how. So, but hormones will definitely have a beneficial effect. That's why a lot of people talk about, like, when women are pregnant, like, whoa, your hair looks so great. Well, they got lots of estrogen
and progesterone, right?
They have a lot of everything, actually.
Yeah, of everything. I would just add on to Sue's question, because we are assuming it's low estrogen, estrogen that's causing, or high testosterone causing their hair loss. However, it's the I would also add on to this mix, just to also get your thyroid checked, because that's low thyroid function is a big cause, right, for hair loss.
And it's interesting. Right. Thyroid is involved in everything. And there's an interesting interplay that most people don't know about. I'm glad you mentioned that, because estrogen upregulates the thyroid receptors. Yeah. So, it doesn't matter how much hormone you have if the receptor isn't, like, we're not open for business today. If the hormone can't get in the receptor to actually create the effect, then it doesn't matter. That's like insulin. If you have all high levels of insulin resistance, you can have lots of insulin, but the sugars don't get into the cell because the insulin isn't working, because the receptors are not working. They call that resistance, right? So you actually get thyroid receptor resistance if you don't have enough estrogen. And you could get a thyroid blood test. So you measure TSH, free T4, and they all look normal. But the woman has every symptom of low thyroid. She read on Google, blah, 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 constipation, hair loss, sluggishness, brain fog, weight gain, every symptom of low thyroid she has. She goes to the doctor and says, no, your thyroid hormones are totally normal. And then he walks away and says, another crazy lady, because she should be on Prozac. But, you really are functionally hypothyroid, because the thyroid hormone isn't activating the receptor properly. And estrogen actually controls that. So essentially, every woman, as she loses her estrogen and goes into the transition into menopause and thereafter, is going to be functionally hypothyroid. That's a fact. So that underlies a lot of the symptoms. That's why these hormones work in this beautiful, like, symphony. That's what they call it, the symphony of hormones, because they're all interlinking. Like, if you have chronic stress and you're reproductive, that's going to tremendously affect your ovarian production of hormones, right? So that's why chronic stress, and women start skipping their periods, or they have fertility problems, because every hormone links to every other hormone. So I'm so glad you brought up the thyroid issue, because absolutely that is a big player in a whole variety of ways.
Just for a recap, Dr. Felice Gersh is who I'm talking to today. Menopause 50 Things You Need to Know. Her lovely book that's available on Amazon. You can get that right away. And it just came out. And for those of you who want to contact her for private consultations, she is available. And this is so unusual, I have to say, because so many people are leaving private practice and you're still going. And so I want to just commend you for that, because
I'm very old fashioned. I still, I do the one-on-one, and I do, like, I just feel like we can't all be virtual and not have any,
absolutely.
Physical exams, and sometimes my patients need procedures. Like, they have abnormal paps, I got to deal with it. They have abnormal bleeding, I have to deal with it. I'm still I'm just still an old-fashioned doctor.
And in full honesty, we have women who follow our, my work and recommendations, and and heal completely and get quality of life that is amazing. There's others who get 80% there, but the 20% is still missing. And there's others who, get the 20% improvement and things are still highly symptomatic. And this is where, if food and nutrition and herbs and supplements aren't enough, then we're going to look further and peel the onion. And this is where, you've got to have a one-to-one consultation with a functional practitioner who understands bioindividuality of a person, and someone like you, like exactly what you're doing. And for those of you who want private consultations with Dr. Gersh, she still does them. And she is available at, you can check out her website, integrativemgi.com is the website. Yeah, I feel like I'm going to talk to you. I have like another 10 questions in my head, but I want to be very respectful of your time. And I have a feeling like we're going to, if you're willing to, I would love to have you back here again for maybe like something more specific symptoms we want to focus on and dive deeper into, and help our audience understand that better. Hey, you guys, thank you so much for being great troopers on the for a lot of your great questions. If we haven't answered your question, then what I'll suggest you do is follow. Do you have any social media pages that they can follow?
I do. So I do most every week. I do an Instagram live for just a few minutes, so it doesn't take up too many people's time, and then it does get archived on my YouTube channel.
Okay.
So you don't, if you miss it. So my Instagram is Dr. Felice Gersh, and if you just also, you can Google me. So it's Felice and the last name Gersh. You'll find lots of stuff online and so forth. And you can also just call my office anytime. And it's the name of the practice is Integrative Medical Group of Irvine. And I'd love to meet any of you, and then see what your own personal journey might be like to maybe make it better.
There's questions about what is the name of the book. Just you can Google Dr. Gersh, and the book is Menopause 50 Things You Need to Know. It's available on Amazon. All right. Well, thanks, everyone. I hope this was helpful for you to get a better scoop on menopause and the bioidentical hormones. These questions we always get a lot of. Thank you so much for your time, for being here today with us. Such pleasure to talking to you. And I'll see you guys next week on another series of lives. All right. Bye for now.
Bye-bye.